From the heartland of the United States and one of the leading children's medical centers in the world, welcome to the Children's Mercy Kansas City Pediatric Bioethics webinar series. We invite international leaders to discuss critical and controversial issues in bioethics. Now, from the Bioethics Conference Center on the Adele Hall campus, here's Dr. John Lantos.
Hi, everybody. Welcome back. Happy New Year from the Bioethics Tower right here in downtown Kansas City. We're thrilled to have you with us. We're thrilled to have Janet Malek, who I will introduce in a few moments. But first, I have to tell you about so much that's going on here at the Bioethics Center that you'll want to know about. First of all, if you want to apply for our Pediatric Bioethics Certificate Program, the deadline for that, the absolute final deadline, is January 15th. We have just a few spots left. If you're interested in this 9-month-long, mostly online program focusing all on pediatric bioethics, and you're an experienced child health professional, go to our website, get your application in for that. It's a great program. Second, we are doing an intensive workshop on difficult conversations in the NICU that we're going to do with our simulation laboratory. We have our own faculty and a bunch of national experts, including Christy Cummings from Boston Children's and Gina Geis from, I'm going to forget, help me, Syracuse, Rochester, somewhere in upstate New York. And she'll kill me for saying that. Coming in to do this SimLab workshop. So if you're interested in that, we have just a couple of spots left for that as well. So go to our website and sign up. We have some great webinars coming up as well. Next week, Kimberly Zeiselman, an expert on legal and medical issues concerning transgender youth, will be doing a webinar. And on February 12th, Danielle Ofri, who writes for both the New York Times and often appears in the New England Journal of Medicine, will be talking about doctor-patient communication. For those who haven't been here before, here's how the webinar works. Professor Malek will speak for about half an hour. After that, we will take questions from the audience. If you want to ask a question or make a comment, type it into that little chat box at the lower right-hand corner of your screen. You can do that at any time during the webinar. We'll then read those out and have a discussion. Or if you're not into typing into the chat box and are more into Twitter, you can go to #CMBioethics and send us a tweet, and we will read those out as well. So it's a great pleasure to welcome Janet Malek, who's Associate Professor of Medicine and Medical Ethics at the Baylor College of Medicine's Center for Medical Ethics and Health Policy, and she also directs the Biomedical Ethics Program at Houston Methodist System. She's written widely about professionalism, about genetic screening, about ethics consultants, religious beliefs, about children's best interests, and many other topics. You should Google her works. They're great. And we're thrilled to have you here to talk about Knowledge is Power, Parental Perspectives on Genomic Sequencing for Seriously Ill Children.
Great, thank you. Perfect. Yes, thanks so much. I'm excited to be here and talk about some interesting work that we have been up to lately. So everybody, I think, is fairly aware at this point that genomic sequencing is slowly becoming, or maybe quickly becoming, increasingly integrated into clinical care, particularly in pediatrics. And there are all kinds of different clinical contexts in which this technology is being integrated. So the ethics of using this technology in adults, which is where most of the work has been done, could be very different from using it in children. And using it for healthy adults or children might be very different from using it in sick children or adults. So what we wanted to do is get a better understanding of another clinical context. At this point, because genome sequencing hasn't been particularly well integrated previously, it's just starting to become part of clinical care, we've done a lot of our ethics work from the armchair. We've kind of sat there and thought about it and projected what we think people might do or what they might worry about or how they might feel. But the purpose of this project is to actually get some some good data about how people respond to the integration of this technology into their care. So I want to be very clear that this is one piece of a much larger project called Basic 3. And Amy McGuire, Will Parsons, and Sharon Plon from Baylor and from Texas Children's are our PIs on the project. I've also worked closely with Stacy Pereira, Melody Sleshinsky, and Larry McCullough on the faculty. And we also have to say show huge appreciation for our research staff who are outstanding, Jill Robinson and Amanda Gutierrez. Because this project did involve sequencing of actual patients and of a lot of actual patients, this was a much bigger project than obviously anyone, even just in our center, could take on. So I want to make sure to acknowledge all of the work that went into this project. All right, so a little bit about Basic 3. It's an NHGRI-funded CSER program. CSER stands for Clinical Sequencing Exploratory Research, about what happens when we do integrate information, genomic information, into clinical practice. Part of it certainly has a clinical piece to it, but we also have an ethics piece about evaluating how parents and patients respond to this information. So Project 3, which is where most of this data comes from, was a qualitative study of the experiences, attitude, and judgments of, first of all, pediatric oncologists who were doing the work, but then also the parents and the children who were impacted by that decision. So we really wanted to understand it from every angle. Here's our little study diagram. We started with 280 children who were newly diagnosed with cancer, and invited them to participate in the Basic 3 study. When they did, they had whole exome sequencing performed, and also their parents, the patients and the patient's parents were screened. Their results were returned to them, and then we did another set of interviews a year after. So the focus of this project that I'm going to report on today is really describing families' perspectives on this technology. So we did semi-structured interviews with parents at pre-disclosure, so after they had done the testing but before they got the results, because there was a fairly substantial gap of several weeks between the time of the testing and the time that they got the results. The post-disclosure surveys happened a little bit variably depending on when they were already coming into the clinic, but 1 to 8 months after they got their results, and then we did follow-up studies. As you can see, we lost folks to attrition. We chose not to interview certain parents, especially those whose children had passed away, things like that. So we did expect some attrition throughout, but we're still able to interview 25 parents at the end. So this is one of the more robust studies that's out there in terms of quantity and longitudinal work. The interviews were really widely broad-ranging, open-ended questions about sort of the roles that the provider and the parent played in decision-making, what they perceived to be the clinical impact, how it changed their treatment, what they expected from this result or from this information in case of recurrence, and sort of what they thought were the benefits and concerns. We did a qualitative thematic analysis using both sort of deductive and inductive approaches. We started with some theories, and then as we read the interviews and did the coding, new codes came up. It was very open-ended, and we used consensus coding among the research team. So after going through all of the results and reading through these interviews, we've kind of come up with 2 buckets of results that we think are particularly interesting. There was a lot of interesting stuff that came up, but I want to report on 2 that we've kind of put together and to sort of show something new or interesting about how people are using this technology and what they're thinking about it. So the first has to do with utility. All right, so utility is a term that is used to mean something fairly specific when we're talking about genomic screening or genomic sequencing. Clinical utility is becoming defined as how it changes clinical practice. And not just how does it change clinical practice, but does it actually show benefits? All right, and this is kind of in contrast to what is often called personal utility. I've put it in scare quotes here because I don't really like that term very much. I think it's kind of been used as a catch-all, and we're actually working on another project now to really try to unpack what we mean by personal utility and try to get a sense of what are the various facets of that might be. But for right now, personal utility is kind of, it takes a back seat. I think most of the time people see it as less important, or funders especially, and to some degree clinicians see that as less important, sort of a secondary ranking consideration. The ACMG has recognized this sort of narrowing of the focus of what we think about when we're talking about the value of genomic sequencing. And this is a piece from 2015 where they're actually criticizing this narrowing of our understanding of utility. So they say it is typically considered not even to be sufficient to establish a diagnosis. It has to change practice for the better and to have evidence to show that it's doing that. They also want to narrow the scope of clinical benefit only to the individual who is receiving the services. So even if it would have benefit for other family members, the insurers don't really want to pay for that, is how the trend is going. And ACMG is criticizing this approach. And our finding was that parents of children who had cancer take a very broad view along the lines, if not even more broad than what ACMG is proposing. They really explained all kinds of reasons why they thought this was interesting, why it was valuable, why they would do it again, that had very little to do with clinical utility. So that's the one thing I want to give you a little bit of insight into for the first few minutes. So here we start off with clinical utility for the child, which is kind of the narrow definition that we would typically think of. In this case, we heard from a parent who underwent the sequencing and they didn't find anything. It was a negative result. So this is a negative result, they would believe that it's still valuable. Even though this wouldn't fall under traditional clinical utility, they're still very optimistic that when they come back, if the cancer were to recur later, that they would have their own regimen and treatment plan, which we can talk a little bit later about how realistic that is, but that is certainly something that that parents hoped for and saw as potential value in using this technology. Because of the delay, I should just explain that because of the delay and how long it takes to get the sequencing done, these children were put automatically on the standard treatment for whatever cancer they had. So we would not have expected a lot of immediate changes in their clinical care, but this is one reason that they found it valuable from a sort of clinical perspective, even if it wasn't immediate. All right, so the parents that we spoke with, and perhaps partially because we were talking to parents and we only spoke with a very few children after they attained the age of majority, but they talked about the value of it for their children, but also really talked about it for the value for themselves, for their other family members. So this is a family who got a secondary finding related to a risk of heart disease. They said we had an investigation with the cardiologist to see us since we have this type of gene. We don't know when it's going to show, so we will keep informing next generations and making sure that they check on this, especially that treatment is available and precautionary medications are available. Just in case, we will let everyone know that we have this. They were very grateful to have the information, even though it had nothing to do with their child's cancer care.
Can I just interrupt for a minute? It also sounds like they were asymptomatic. Is that what it means? We don't know when it's going to show?
Yep, they were asymptomatic.
Okay.
But they were medically actionable. So that's why it was returned. Secondary findings that were medically actionable were returned.
Got it.
All right, so that's sort of the more traditional version of clinical utility. And for the purposes of this typology, we separated personal utility into psychological utility and pragmatic utility. So here are a couple reasons that people found this information to be beneficial, to have value for them psychologically. So they provided their child with some peace of mind, but for the parents, you see they talked about peace of mind, avoiding guilt, and really just being grateful to have the information just for the sake of having information. I guess this gives peace of mind at some level for her that there's not an inherited mutation. I guess there's another peace of mind about the tumor mutations, which was a separate genomic sequencing process. Their whole genomes were sequenced, but then also the tumor was sequenced. And some of them got tumor mutation findings also. They were grateful that they learned that they didn't have something more bad news to be told. They were relieved to find out that there wasn't more that they needed to know. Of course, the study doesn't point out exactly what caused it or exactly why that was. This was one of the huge motivations that parents had. They wanted a diagnosis. They wanted not a diagnosis, but they wanted to understand where the cancer came from. So many parents before in the pre-interviews said they want to understand where it comes from. But here's one expressing some frustration. We were really hoping that we would get some answers, but I guess we're not there. That was the only disappointment. Otherwise, the information we have is not so bad. All right, here is somebody who is saying that they just are interested in this information just because it's something more they know. I want to know everything there is to know about our child. It doesn't affect me emotionally or mentally to the point that I'm worrying about it all the time. It's just really interesting to find out these things. All right, and the final piece of the typology that we are talking about here is pragmatic utility. And here again, they saw the possibility for future planning, including reproductive decision making, as affecting not only their child, but themselves and other family members. We definitely utilize that information. I think it would give us a much better in-depth picture. Oh yeah, so she will not be marrying any French Canadians from Quebec, which ironically one of my best friends is. So here they're directly applying it to how it might affect their decisions, their child's decisions with respect to her marriage options here. So that's with respect to the child, and here is a parent who talked more about their own decision making. So now it's like, if we ever do plan on having more children, it's kind of like we have to go get our genetics testing done first before we even think about having a baby. And then while I'm whatever I do get pregnant, then we have to get the genetic testing while the baby's still inside of me. So it's a lot to think about. All right. Moving on to sort of the second, so here from utility, basically the goal there is that you see there's a wide array of ways in which parents found this valuable beyond the simple clinical utility. All right, another theme that came up that really didn't seem to fit quite into the typology, it's not really utility or a benefit in the same sort of way, but a theme that came up again and again in our interviews, even though parents were not asked about it explicitly, is how this relates to their feelings as parents and their role as a parent and how they interface with this technology from that perspective. And we kind of have come to think of this as a layer of meaning that parents add to genomic sequencing that might not be apparent initially to a clinician or to an insurer, but it affects the way that they make decisions about the use of these technologies, and it seems to also affect their experience with the technology. So this surrounds sort of parental culpability and parental responsibility. So I want to share with you a couple of great quotes that that were discussed in the interviews and some of the conclusions that we drew from that. So the question of inheritance is kind of the thing that we obviously think about, right? That we worry that people will feel guilty that they passed on a gene to their children. And we did hear in our pre-interviews a lot of concern about that. So if they found out that they had passed a cancer-causing gene on, they were very worried about that. They were also worried that other people would blame them for having passed this gene on. So this is an incredibly telling quote where there were two parents in the room both participating in the interview. And they said, well, do you have any concerns? The interviewer said, do you have any concerns about this information? And one says, well, I mean, it's not to point fingers. And the other laughs. Oh, he wants to. No, he's the type of person. Well, it's your fault. That's why he wants to know, so he can lay it on. He wants to know so he can blame it on whoever. And then laughs. I'm not sure how sincere that laughter was. No, I ain't going to be playing the blame game. Yes, he is. So this is before they knew the results of the test. But you can see this is clearly something that was in this couple's mind. And I hope they've had some help to work through these issues since then. Here's a person saying that she's worried about feeling guilty. As much as I want the knowledge, let's say I do find out I'm a carrier, then that starts the whole emotional processing of it. It's like the guilt, and it's now my fault. How do you deal with that? So this is definitely part of their narrative. We have a couple of quotes that from parents from the follow-up interviews, citing that they were relieved that they hadn't passed on a gene to their child. It was a relief. I mean, they had already told us that they were more than positive that it wasn't a genetic type of tumor. So that was good. But then just to hear them actually say it from all the tests was good. So that made me feel really good, not to be blamed. And similarly, there was a lot of information, but I just think my mind stuck on that. And it was just sticking right there that it wasn't us. It wasn't us. I was just very joyful. So these people got a lot of benefit from the negative results. All right, so that's one, a relief from worry about guilt, and then relief from that guilt about inheriting a gene. It was one big theme that came up. A second theme that has not been very well discussed or explored has to do with the possible guilt of parenting decisions that the parents had made. So they wanted to look to genetic testing to get off the hook, basically for worrying about that they had done something that caused their child's cancer. So here we heard this cell phone commentary in multiple interviews. If I found out that this is a pre-interview, if I found out that it had a genetic cause, there's nothing that would be great. There's nothing you can do to prevent it. It would make me feel a whole lot better. And I know that I caused it. I think she's saying, and to know that I didn't cause it, all of the fact that it's something I did, that I gave it to her to eat, something that she ate, or something that maybe I bought her a cell phone too early in her life. It would help me in my way knowing that I didn't fail as a parent that way. So she's here using this as a sort of lifeline to not have to blame herself for her child's cancer. After getting their results, this person also got a negative result, that there was no genetic finding. But they still appreciated having that information, saying that it makes it easier because it sort of helps me with, I should have known something was wrong a long time ago. It makes me realize that there's absolutely nothing I could have done about it, and the genetic people don't even know why he got it. So it's not like it was something I missed. Nothing I could have done differently in terms of getting genetic testing. Finally, the last sort of theme that relates to this layer of meaning has to do with responsibility. We had several parents say that they believed that when they were deciding to do it or not, they felt like it was the only responsible option. So before the results were returned, this parent said, hopefully they'll be able to find something, I guess. I just want to make sure we did everything. If it does, it does. I just wanted to make sure we did everything that we could. And this was a post-interview quote. As I said, we wanted, and from a different parent, we wanted to make sure that as a responsible parent, we are doing everything in our knowledge and understanding to make sure that we know about everything that our child has gone through and is going to go through so that we are prepared for everything that's out there. So they really saw this as a way of sort of discharging their parental obligations in a situation in which many of them don't feel like they have much power, much authority, much ability to do anything. This is one decision that they could make that would help them feel like they're doing the right thing. So we found this set of considerations probably affects parents in their decision making and their experience with this technology more than maybe we had previously realized. So there's some interesting sort of conclusions to draw and then questions to raise from this information. Just to summarize quickly, parents of children with cancer find genome sequencing valuable in many ways beyond just the way that affects their child's clinical care. And this idea that parenthood changes the way that people think about this technology and decisions that they might make about it. All right, so what kinds of questions does this raise? First of all, should these considerations count as benefits or as potential harms that could justify recommending or paying for sequencing in some circumstances? So should payers take this into account when they determine whether they should reimburse for these technologies? And should physicians think about them when they're deciding to make a recommendation, or should we really be sticking with clinical utility? Secondly, as you probably noticed in a number of the quotes, parents' reasoning about this technology isn't always fully informed and fully rational. There were times that they interpreted negative results that as peace of mind, which might not really be entirely justified, since we made it clear that we can only search for certain cancer susceptibility genes. There were also a number of the quotes in the sort of guilt and responsibility work that we did, where they kind of were going to feel guilty no matter what happened, or they were going to feel relief no matter what happened. They kind of could interpret the results in different ways, right? The fact that there is a genetic mutation that caused the child's tumor, that was sort of a spontaneous mutation in the tumor itself, they found that to be a relief, but it's not really clear from a medical perspective that that gives any sort of, relief of culpability from anything that they had done. So how do we think about that, and does it matter that it's rational or irrational, or was what's more important how they feel about it at the end? How should these insights shape our consent conversations, right? Should we be talking about these sorts of possible outcomes, possible ramifications, or should we be acknowledging the fact that this is a narrative that parents may have going on in their minds when we offer technology to them, right? Do they really feel like they can say no? And if so, should we be, or if not, should we be trying to encourage them to be more open-minded and recognize the feelings that they may have and distinguish those from their decision making? And finally, I think in pediatrics it's particularly interesting because obviously parents are making decisions on behalf of their children. But as we heard, an awful lot of the narrative that the parents at least told us had very little to do with their children. It had much more to do with their own feelings, their family considerations, the possibility of having future children, things like that. And how should those impact our decision making about whether children should be undergoing these sorts of sequencing interventions? So I don't know if anybody has comments or questions on those? Or
I have a few, but thank you. That was great. You have a few. Remind people. Yes, we are now open for questions. If you have a question or comment, just type it into that little chat box in the lower right-hand corner of your screen, and we will read them out. I have a few questions. The first one is just methodologic, and has to do with the fact that most of the quotes seemed very positive. The parents really liked this. How many people didn't consent to be in the study? Was this just selection bias, that people who consented to be in the study were people who wanted genetic results?
There were a number of people who declined, and we did survey those folks. Most of them said they were just too overwhelmed to think about another study at this point, and a few had particular concerns about having genomic information. So there were, I want to say maybe 10 to 20%. I honestly don't know the exact numbers, but it was a minority that declined, but there was a substantial minority.
So at least you should temper your conclusions that parents who agree to genomic testing find results
That's
valuable.
A good point. Yes, for sure.
Second, you started with a contrast between, with the ACMG statement between what payers are willing to pay for and utility, and ended saying, like, parents seem to find this valuable. Did you ask them what they'd be willing to pay for it?
What the parents would be able to? No.
So if it's free, they find it very valuable.
Right. No, that's a great point. And we are doing a follow-up study that's more quantitative, but I still don't think we asked them about what they would be willing to pay. We have the socioeconomic diversity of our population is really substantial, so I think the vast majority of it wouldn't even be an option for them to pay for it.
And I mean, in general, I find people who are paying for things are more likely to try to assess the value of them than people who are getting them for nothing. Because one way to interpret the conclusions would be that everybody who wants an expensive but medically useless test should be able to get it if it makes them feel better. Is that?
Well, I don't think that we're advocating that.
No.
Okay. I think that might be a little more than I want to say. I think that we need to be aware that this is sort of what's going on in people's decision making. I'm not sure it entitles them. I mean, that I think that's really the question, is whether people should pay for this type of value.
But this seems to be supporting the idea that we should widen the way we think about value to patients and parents rather than narrow it as the ACMG fears.
That is a good, I don't think that, maybe I didn't present it correctly. I'm not sure that we have gotten to the stage yet where we're willing to sort of make normative claims about that. I think we just want people to be aware of everything else that's going on here. And we should be thinking about that, and part of the CSER group was supposed to, and is still in theory, working on writing a paper about exactly that question.
And why did they pick the cancer? Why did they pick kids with cancer?
I think it was driven by the fact that our collaborators at Texas Children's were in cancer genomics. Okay.
And did some of the results then get fed back to the oncologists, and did they lead to changes in treatment?
So the results were all given back to the clinicians. The main changes that happened is that some of the patients were made eligible for research studies as a result of their results. Most of them, because they went on the standard treatment to begin with, it didn't affect that first line of treatment. And I honestly don't know to what degree it has made a difference in recurrence. I don't know the answer to that. And I think part of that, we just closed this study in June. So I think they're still working through that to see whether it does make an impact.
So I have more, but I'll open it up to the audience. And people online have questions, type them into that chat box. Go ahead, Jeremy.
Okay, just flashing orange. Okay. The first question asked whether any of the parents made specific comments about whether about how or whether the information they obtained would relate to their other existing children, siblings of the child that was sequenced, and what the results might mean for their chances of developing cancer. Can you say a little bit more about the way that siblings figured into the parental reasoning?
I think it was a pretty substantial consideration for many of them. One of the quotes I had to leave out here, she says, the main reason I wanted to do this study is to know whether I needed to get my other daughter sequenced. So that was definitely a huge, I think probably for more of the parents, and again, we don't talk about quantity really in this context because we haven't explicitly asked them the questions, but talking about their siblings was a very prevalent theme. It was probably less common for people to talk about their own decision making and their families, but it was still definitely there. Did that answer the question, do you think?
Thank you very much. Very interesting talk and research. And I was really curious, does this work?
Yeah.
Should start flashing green.
It does flash green and red.
Yeah, okay. Yeah, okay. So, thank you. I was curious about the last point. You said
You interviewed some children, right? After they reached the age of 18 years old.
so what's their perspective? Because I think even if parents are the decision
makers, they would be informed by what children how the process is done.
Information, if they get what it means,
Mhm.
and if they change their mind throughout the years.
Yeah. So that's a great question. So we were only able to interview, I think, 7 or 8, because it was only those folks who turned 18 during the study period. So they had been the adolescents who turned 18. But we did reach out to them. I think they fell into sort of 2 different groups. One, maybe half and half. So there were 3 or 4 of the adolescents I spoke with who were super engaged, knew everything about their treatment, knew exactly what was going on. And of those that I spoke with, they were still very supportive of doing it. Absolutely, I would do the study again. I would have been happy to participate, or some of them I did participate in the decision making, even though I wasn't the parent. I still, had a say in whether we did it or not, and were completely with it. In terms of being very savvy. And I would say there's another 3 or 4 that took a very passive approach. Nobody was upset about having participated. Some really didn't remember that they had participated. And some were just kind of taking the back seat and were just saying, I just went along with what my parents said. I went along with what my doctor said. And didn't show a lot of interest in being one of the reasons we did those interviews, to see whether they felt that they should be reconsented, because they did need to reconsent if they were going to continue to participate in the study, and how they felt about their participation. And those also seemed to self-select, and they were just as happy to have not participated. So
Go ahead, Brian.
interesting.
So, thank you. It was a very interesting presentation. I heard tidbits emanate from within the responses that reminded me of parental therapeutic optimism, therapeutic misconception, a little bit about the diagnostic odyssey, and wanting to know simply because humans are inquisitive beings, whether it was relevant or not. So I won't go chasing after those, though they might be fun conversations at another time. I'm intrigued by the 3rd bullet point on the last slide here. How should these insights shape consent conversations? So with research, we oftentimes are wanting to optimize consent, understandably, but how should they shape responses? In other words, these parents had a wide range of responses that might suggest that built into a protocol would be supportive personnel opportunities to discuss what it means to be blameworthy. Are you truly blameworthy because you carried the gene, but your mother or grandfather might have carried the gene too? Nobody talks about that. So what does it mean to be blameworthy? What does it mean to think that there's utility when there's not? So how do we address the deep things that emanate from this study to make not only consent better, but the whole protocol and its fullness and sense of, we're doing the right thing here better? And then I have one other question.
Yeah, great. I think that's a great point. We had in our study, all of the disclosures were done by genetic counselors, and they followed up with the patients and the parents after. So there was some, I haven't participated myself in those conversations, but I know that they did offer a good amount of support and explanation multiple times following up with the study, especially if the parents had concerns. So I think it highlights the importance of that as a part of the process. And as we move from research, where we can kind of afford to have genetic counselors and all of the, resources that could possibly be necessary, into clinical practice, where maybe there is no genetic counselor there to give that information, to have those conversations. I think that's something we're going to really need to be thinking carefully about, and making sure that we have that support. The other piece that I didn't report on here, but is in the conversations that we had with the pediatric oncologists after, and talking with them about how they found the experience, one thing they said across the board is how much they appreciated the genetic counselors and the role that they played in this study. So I think that only emphasizes how important it is.
So that leads me
Can I
back.
just follow up on that a little bit before you get to your second one? I mean, I'm glad the genetic counselors were there. I don't think of genetic counselors as having expertise in dealing with questions of guilt and blame. Were you thinking genetic counselor or a psychologist? Are there any genetic counselors online who could speak to this?
I think genetic counselors have a skill set to offer, but it might not reach the full extent of the psychosocial, the existential wondering that these folks are doing. But yes, but the genetics counselors is a great segue to my next question, which really has to do with the grand parallel of this experiment to cystic fibrosis screening 20 years ago. I distinctly remember a paper by Norm Faust who said, yeah, cystic fibrosis screening is going to require genetic counseling. We don't have the depth, the capacity of genetic counselors to do much more of this. And I think he was forward thinking about other genetic tests, which have indeed followed. But then we put that in the context of cystic fibrosis screening in pregnancy. And women who would choose to have it done or choose not to have it done for the very same reasons that you've elucidated in this regard with the cancer population. Will it change how I think about my child, my pregnancy, me, myself, culpability and blame, opportunity to do something to perhaps terminate a pregnancy and cut short a life of misery, which was certainly more true 20-something years ago than it is today for children with cystic fibrosis. But I think there are grand parallels there that you might draw upon in finally, formalizing a manuscript.
I will have to look that up. I don't think I've read that paper, so I'll have to see how that might inform our work. Thank you.
You have another one? Okay, take it away.
We've got a whole host of questions kind of coming in asking about stuff related to study design and demographics. So I'm just going to kind of go through these. Should be pretty quickly, I would think. Can you say if there were any similarities in the demographics of the population of parents who ended up consenting to be tested? Were there similar socioeconomic status, education, anything like that? Can you just tell us a little bit more? No, the ones that did consent.
You mean a difference between the decliners and those who accepted?
No, I think they just want to know more about the people that you interviewed. Were there any commonalities, or were there any preponderances?
Right. I should have put that slide up here. Sorry about that. It was a very diverse group, so there was. My research folks are going to kill me.
Ballpark figures.
Maybe 40% white, 30% Hispanic, and then 30% African American, and then and other Indian.
Looked a lot like Houston.
Yes, yeah, it did. Because Texas Children's is really like kind of an all-comers sort of place, so they're going to give folks care there.
Mm-hmm. An education level similarly diverse from not even a high school education all the way through advanced professionals, yep. I'm assuming.
Really vary. I wouldn't say there was like a preponderance of anyone. Some of the other studies that have been done have ended up being with sort of narrow demographics, but one of the reasons I think we were able to kind of pull this into our second project, which we're starting now, is because Houston offers us the opportunity to really get a diverse group in all ways.
It is the most diverse city in America.
It is. Then some other questions wanted to know more about the decisions about who to interview and not, and how to encourage people to want to be part of the study. So one person asked, what influenced the decision to not interview parents who had a child who passed away during the study?
Right. So I think that I actually was not part of that conversation when it took place, so I don't know exactly, but I think it really just had to do with sensitivity to the difficulty of that experience. I think that we are maybe going to do that differently this time around to try to get, we found that the parents, I want to emphasize that this is parents of children who've just been diagnosed with cancer. So their world is just turned upside down. They're willing to do anything. I mean, not anybody, I'm overgeneralizing here, but in general, they see any opportunity to do everything, to explore every rabbit hole, to like pretty much do whatever they would want to do. I mean, whatever they have the opportunity to do. So not that many said no. Most of them said, yes, I'm happy to help. And even a year later, they said, yes, I'm happy that we participated. If there's anything that I could do to help the next family who has the same experience, I would want to do it. So I really do believe that the parents of those families, many of them probably would be willing and maybe even appreciative of the opportunity to share their perspectives. But I think it was just kind of trying to be cautious and not put ourselves.
As far as you know, then was that a decision by the researchers, or was it an IRB kind of level decision?
I believe it
risk?
was the research team.
Research team itself chose to do that.
I believe so. Somebody can text. I think some of our team members are on. They can say, Jill, let me know.
Yeah, chime in. There are good studies showing that parents do not usually feel upset if they're contacted after a child dies, and in fact, often feel grateful to be able to participate again. So I would encourage you to go back to those parents and see if you can get them.
So based on your experience with the parents who did enroll and those who chose not to, do you have any advice about measures that could be adopted to encourage participation in future sequencing studies?
That's a good question. I do think that.
Well, you did say you might do some things differently in future research. I don't know if that would be a place to kind of go with this. Like, what did you learn about your process that you might want to tweak going forward, that you might suggest people avoid certain things or frame it a certain way, or I don't know exactly what all the person might be have in mind. And whoever typed this, feel free to follow up if you are not getting the answer you're looking for here. But
yeah, and so I didn't myself do any of the consenting. So our research, team would probably have a better insight into that. But I think we have tried in our second round of reaching out to families. We have now we're doing surveys the second time instead of interviews, so it's a little bit different. But we're trying to keep them as short as possible, so it's the smallest burden possible. 2, this time we're actually requiring them to complete this part, the pre-disclosure survey. Before they can fully enroll in the study. So it's a pre-requirement, whereas before we just asked them if they wanted to do the interview, whereas now like participating in the ethics piece of it is required. So that maybe will help.
So real quickly related to the length of the interview, do you tell them up front what roughly they're looking forward to? Because you did say it was a very open-ended question, which could lead to people talking for a long time, presumably. And so how did you frame it in terms of what they were signing up for in the interview process? And I know you didn't do the consenting, so maybe you don't know exactly, but do you have any sense? It was
probably like 30 to 40 minutes was the expectation that was set. But some of them were 15 minutes and some went over an hour.
Another person did ask about the role of genetic counselors, and you've kind of spoken to that now, and it seems like they had an important role in the process. Is there anything else you would say about their role?
I think just how important it is. Yeah. No, I think that was definitely our takeaway from that. And we in some of our off the sites that did the studies, they didn't have a genetic counselor on staff with them, and they did it through telemedicine, and that still seemed to be a fairly acceptable way for most folks to do it. So it's better than nothing to do it that way.
So one follow-up on that as well, and it gets back to this question of cost and coverage that we mentioned early but have not attended to in the Q&A session. Genetic counselors often are integrated into maternal fetal medicine specialists' practices. So they have an established role. Addressing cystic fibrosis was just one of many tests now available, as you know. But for whatever reason, insurance covers cystic fibrosis screening. So that again might be a model to look at what facts you can bring to bear to leverage insurance coverage for whole genome sequencing in time or not.
Mhm.
You have a tweet? Go ahead. Take it away.
So this one comes via Twitter, and its question is, how would you advise researchers and IRBs to conceptualize your findings in terms of risk and benefit?
So I think that's a great question, and there's a little bit of subtlety here that I'm trying to tease out. I think you could kind of see the utility piece is kind of one way of thinking about risks and benefits. I don't think that sort of relief from guilt, I mean, it's utility, but it's something a little bit different than that. So this latter set of considerations about parental responsibility and things like that, is that a risk or a benefit? I'm not sure it really should be considered that, but it's not that it's unimportant because of that. So I think that's kind of one of the points that I'm trying to make, is that there's value, but then there's like all of the other narrative that affects the experience. And I don't think it can simply be boiled down to risks and benefits. Like, you wouldn't put some of these things in a consent form, right, as a possible benefit. You may feel like you are fulfilling your parental responsibility by doing this, right? That's not how these results, I don't think it makes sense in terms of that. That being said, some of the other things, the other pieces of utility, I do think people have seen as risks and benefits. So for example, the fact that these results might cause you anxiety is clearly something that has been found on a consent form, right? So where do we draw the line between those two things, in which I don't have an answer. I think it's something that really needs some thought and some systematic examination, not just sort of saying what we sort of think from shooting from our hips about that.
And again, to follow up on that, there's a piece of this with the culpability and responsibility domain that you were talking about that makes genetics seem unique. I mean, people often raise questions about whether genetic tests are just like MRIs or, CBCs. But this idea that a married couple, say, would be assigning blame based on whose genome the bad gene came from doesn't come up with other kinds of tests.
Right.
At the same time, the relief from guilt when you find out it wasn't genetic, we didn't have it, doesn't come up with it. So there's a unique benefit, that relief from guilt, as well as a unique kind of culpability.
It could go both ways.
Yeah.
Right. So the interesting thing that we found is that the way that folks tended to think about it, if they said, I'm worried that I passed it on, they don't like that idea. But they also don't like the idea that they did something to cause their child's cancer. So in some ways, and we didn't have anybody for whom this was the case, but I think if somebody had been very afraid that, like, oh, I let my kid have that cell phone too much, and then instead they found out that it had a genetic inheritance, I almost feel like maybe they would have found that to be a relief from guilt too. Even though they passed on the gene, at least they didn't make a decision. That was their own choice to let them do that.
Yeah,
so I think there's a lot of adaptive
culpability and adaptability, because we know that parents blame themselves for every childhood. I mean, every NICU parent thinks, I did something wrong, that's why I had a premature baby, whether they've gotten a genetic test or their kid's been on a cell phone or whatever. I mean,
but does this guilt thing
change it? Yeah.
Speak to no general competency about genetic information across the public? In other words, because I don't really understand genetics, I'm either going to receive absolution because it wasn't me, or I'm going to feel guilty because it was me. But that's only one of how many genes that you pass on that you had no control over. So this lack of competency of the general public in understanding genetics, I think, may be at the base of some of this strife.
It's a really interesting question because even though it's in some ways irrational, in most ways irrational to feel guilt, even if we said you did pass on this gene, like you didn't make that choice yourself. There was nothing that you did that would hold you morally culpable for what happened. People, I think they know that, and they still feel the guilt or worry that they will still feel the guilt. Now, maybe that could be resolved with education, but I'm not 100% sure. I think that they might still feel, even if they had 100% clean understanding of what exactly genomics is and how it gets inherited, I think they might still feel that.
Yeah, I'm not sure you could educate guilt away. Reminder, if you have last questions, we have a few more minutes. Type them into that chat box or tweet them to #CMBioethics. We have a couple more from our online audience.
Well, we've got one from me, if that's okay.
Yeah.
So I've got a little bit more philosophical question about the first of the ethical questions you have up there. So I'm really interested in this kind of taxonomy of utility into different categories, and but I can see that going two different directions, I guess. So like one is to try to say what's in the clinical utility bin or bucket, and distinguish that from other bins or buckets, and with the idea being we want to say that only the clinical has any relevance for medicine. That's all they should be focused on, and we want to limit the responsibility of medicine to that set of things. And so, but you can also imagine a way of going about this where you just say, no, it's perfectly fine for doctors to try to help people have other kinds of utility, personal utility, feeling, relief from worry and these sorts of things. I mean, we do that all the time, after all. But it's just not, we don't weigh it as heavily as we do the clinical value. So you can imagine going one of two different directions with that. And I really try to resist the idea of doing it by definition, by saying, well, medicine only focuses on this little thing and it can't ever legitimately pursue anything in the other buckets. I know you guys haven't taken normative stances as much with this research, but you have to have kind of discussed some of this and maybe started thinking about it. And I'm wondering if you want to say anything on your own thoughts on going forward about that, because I'm inclined to say we should consider paying for any value that's created by this, but it has to be weighed against the costs, and it's not always clear that it's worth thousands of dollars to know that little bit about your child that you didn't know before.
Disclaimer here, none of these views are the views of your research team.
Yes, exactly. I realize that, but I'd be remiss as a philosopher sitting here not to at least inquire and see where your thinking has gone based on this. Because it does, as John said, it says very positive stuff, it seems like.
Yeah. I think I am inclined to at least leave the door open for some of that. I really saw the incredible relief and they really felt, many of the parents really felt like this was an incredibly valuable thing for them to do. So I'm reluctant to say that shouldn't play a role in the decision making. And you're absolutely right. We do that all the time. At the end of life, we keep patients alive for weeks so that a family member can come in. And I mean, it's not about the money, right? It's more, like you said, about the what is it that is within my purview as a clinician to offer, and is this the type of thing I should be doing? And I think that we do offer a lot of things. So my inclination is that insurers should be paying for a little bit more of this than they are, but that doesn't necessarily mean that it's like anything.
But I bet most families would have been happy to get the sort of results that they'd get at Ancestry.com. So you could have done genealogy on these samples.
Well, let's start a whole
and I'll bet they would have been highly satisfied. And therefore, we should provide it, right? Insurance should pay for it. Go ahead. Last question on Twitter.
So this is actually just a response to your previous response, but I think it's a good one. It's probably a good place to end. So they mentioned, thanks for a great, interesting answer. Thought Dr. Malek's answer in the subsequent discussion raises the question of whether risk and benefit is just about psychological experience of anxiety and relief, or should emphasize, in quotes, accurate, in quotes, rational psychological reactions. Mm-hmm. Well done.
Thanks.
We need to stop. Thank you all for joining us. Again, Happy New Year. Let me remind you, next week, January 16th, that's Wednesday, Kimberly Zeiselman will be talking about some ethical issues that surround treatment of transgender youth. And on February 12th, Danielle Ofrey will be talking about doctor-patient communication. So thanks for joining us. See you next week.